Kia ora and welcome to my talk on the histopathology of precancerous lesions, the difficult diagnoses. So we're in the cervix again. My name's Diane Kenwright and I work for the University of Otago, Wellington and Wellington SCL. What we're going to cover today is we're going to illustrate difficult diagnoses in squamous intraepithelial lesions, how P16 and Ki67 can help, the H&E diagnostic clues, and then we're going to venture and think about a few glandular lesions. But first, to start, I want you to look at this slide. Just take a moment or two and write down and commit whether you think this is CIN1 or CIN2. Off you go. Okay, that was CIN2. How many of you got that right? I generally find about 60% of people will call that CIN2. The rest will call it CIN1. Here we go. How about that one? Now you've seen the CIN2, you can see that this one is in fact CIN1. It's much lower grade. 3 more. This one. You can always pause the video if you need a bit more time. Okay, this one was CIN1. This one. This one was CIN2. And this one. This was CIN1. Now, if I had you all in the room, there would be disagreement in diagnoses about these, because this is a particularly difficult area. It's the CIN1, CIN2 border. And that is one of the 2 most difficult problematic decisions that we make in squamous cervical histology. The other one is between inflammatory changes and CIN1. So every day I'm thinking about those diagnoses. So what do we do? So if you're a registrar, you show it to your consultant. If you're a starting out consultant, you show it to a more senior consultant who specializes in gynae. And if you're a gynae specialist like me, you show it to your other gynae specialists. So reaching a consensus is important. But before we do that, perhaps that should be step 1 actually, we do biomarkers, particularly P16. Okay, so P16. P16 staining is absent in normal squamous epithelium and benign inflammatory reparative conditions. Absent. What do we mean by absent? So normal squamous epithelium generally shows completely absent expression, but you've probably all seen that scattered, cloudy looking weakly staining pattern that's present especially in immature metaplastic epithelium, and also if there's inflammation. So when the squamous epithelium becomes reactive, we get more prominent P16 staining, though these are still very, very irregularly scattered. So here's some examples. Here we can see in this picture here, we've got this cloudy spotty pattern, also in the glandular epithelium. So P16 abnormal staining is absent. Here again, no, this looks like CIN1. We've just got this fluffy staining, and here completely absent staining. Here's normal cervical squamous epithelium with the typical patchy staining, looks a bit inflamed through here, and the normal glandular epithelium with patchy staining. One pattern that you might see sometimes that's quite unusual and can be a bit tricky to interpret is that in immature squamous epithelium, sometimes you get this staining that runs along the top of the epithelium, but the basal layer is negative. So this is still doesn't qualify for P16 block positive staining. Okay, this is just a variant of the reactive or LCIL pattern. Okay, so let's think of P16 staining in HPV and CIN1. One of the trickiest things is that approximately a third to a half of low lesions, classic LCIL, if you do a P16 on them, will show strong diffuse staining of the basal layer because they're caused by a high-risk virus. About a third show the cloudy pattern that we think is typical for LCIL, and a third have LCIL completely negative. We don't use P16 for grading. We use P16 as a data point to help us decide between CIN1 and CIN2 because of this problem, where you can get integration of the HPV into the host nuclei and it still be CIN1. So we're going to have to combine any P16 staining with our morphologic appearances. Okay, negative versus positive. We don't want to use these words with P16. They're really confusing. So what we want to talk about is the presence or absence of abnormal expression. We can use the term abnormal block positive expression. Yeah. Or we want to say that there is abnormal block positive staining or expression. So the phrase I usually use is P16 shows abnormal block positive staining, or the P16 shows normal expression. And in that way, people don't get confused about what you mean by positive. And you're not thinking, you feel a bit weird when it's actually showing that patchy thing and you're calling it, negative. So I just say normal expression. Okay, so what is abnormal expression? Abnormal expression is solid band-like staining that is at least 1/3 of the epithelium. Okay, so the block positive has to be 1/3 of the epithelium thick. It must be in the nuclei as well as the cytoplasm. And it must extend for at least 6 cells across. No one has a problem with this. Okay, so here's CIN2. We can see that there's a suprabasal mitosis in the lower third, but the abnormal cells go more than halfway. And this shows very typical diffuse block positive staining with nuclear positivity and cytoplasmic positivity. Similarly here, on the left, we were wondering that whether this might be CIN1 or CIN2. We have the basal type cells going up to about halfway, but the P16 shows quite clearly that this is patchy non-block staining for P16, so it is LCIL. And this is where the P16 is most useful. It is most useful when it is showing non-block staining. Okay, let's have a look at this one on the left. We suspect that this has got HPV. It's showing typical coilocytic changes, and there's an abnormal mitosis here, but really the basal cells are, well, pretty basal, There's no basal cells going up into the middle half. So we do a P16. Now, is this P16 positive or negative? I just want you to take a moment and think and write it down. Do you think, I'll use the words positive and negative. Oh, it's such a bad habit. Do you think this shows abnormal block positive staining? Have a think. And then, well, it does. So it was kind of given away this might be CIN2 because of the tripolar mitosis here. But this meets the criteria of more than 6 cells in a row with positive nuclear staining for P16 and it goes above the bottom third of the thickness. So this is abnormal diffuse block positive staining. Okay, other troublesome areas. So we've got a 54-year-old woman. Here we are. She has got this pattern here. She might have come in with an L-cell smear. The P16 is negative, so it's not high grade, but you didn't think it was high grade anyway. So another difficult decision that people often have to make is in older women, postmenopausal women, whether or not the changes that they're seeing are postmenopausal changes or whether they are L-cell. What we can see here, however, is these cells, the nuclei at the top in these cells are very similar to the nuclei at the bottom. In proper L-cell, these nuclei in these haloid cells will be atypical. They will look like raisins, they will be larger than normal, and there will be binucleate cells. So looking at this, we can think that these are pseudocoilocytes and not real coilocytes, and this is a normal postmenopausal appearance. Okay, here's another tricky area. How about this? We have got a very reactive looking squamous epithelium. There's lots of edema down here and lots of inflammatory cells. But up here, we've got binucleate cells, and we've got enlarged cells with halos. So we've got coilocytes and binucleate cells at the top. So is this inflamed L-cell, or is this, in fact, CIN2? What's going on? We've got the P16 here, and it shows block positive staining. So in this situation, it's less useful because we know that CIN1 can have block positive staining. Looking at these nuclei look reactive. They are not showing any irregular nuclear membrane features. They're not hyperchromatic, and they have prominent nucleoli. There's prominent edema. So this is CIN1 with block positive staining. So again, the block positive staining doesn't mean it's high grade. The diagnosis is based on morphology, and P16 is one of the data points. If P16 can stain positive in CIN1, well, what use is it? And the answer is it's most useful if it's negative. Also in CIN1, if there is block positive staining, it doesn't mean that this is going to definitely progress to CIN2. It's not a reliable test. Okay, so other tips for the CIN1 and CIN2 border. Nuclear atypia is always present in any squamous intraepithelial lesion with the atypia, meaning that the nuclei in L-cell at the top are enlarged and have irregular nuclear membranes and are hyperchromatic, the raisinoid cells. So perinuclear halos in the absence of significant nuclear atypia are non-specific, and we often see them in postmenopausal women. Multinucleate cells, the binucleate cells, are a good indication of HPV infection, but not infallible, because sometimes they can always be seen in, sometimes they can also be seen in inflammation. So you gather multiple data points and then you put them together to make your diagnosis, with P16 being a very valuable data point, particularly if it's negative. Okay, let's move on to think about key 67 now. So key 67 is also used to sort out cervical lesions. We know it's a cellular proliferation, and it's most useful for identification of HSIL, where the definition of increased Ki67 is more than 50% increased staining, and 25% of cells are positive in the upper third. If we get those, then we can say that this is a high an HSIL, an HSIL. If the Ki67 staining is present in reparative and reactive epithelium, particularly reparative immature squamous metaplasia, you have to combine it with other things to determine whether or not it is in fact telling you it's an H-cell. So this is another data point. You combine it with the P53 and also your morphologic observations. Again, it doesn't stand alone. So this is normal cervix. In normal cervix, you just get the basal cells staining positive and you don't get any going up. Remember, 50% of cells stain and at least 25% in the upper third in order for it to be an H cell. Okay, so here we go. This is a very typical CIN3. This is the P16, and this is the Ki67, which meets both those criteria. Let's have a look at these. So this one here, this one looks normal. Okay, this one looks well. This one meets the criteria for high grade, as does this. But what about this one? We suspect that it might be CIN2 because it's got an abnormal mitosis and there's quite a lot of atypia. Definitely, there's more than 50% of cells staining. Is there more than 25% in the top third? Probably not. So this Ki67 is non-informative in this case. Okay, let's have a look at this one. So here we have a Ki67. So this does not have a more than 50% staining. Yeah, there's band like P16. So this would be consistent with CIN1. Probably an immature squamous metaplasia looking at it because it doesn't have very typical features at all. Okay, so here we go again. This is squamous metaplasia, right, with just the basal staining. And this is H-cell with more than 50% staining and more than 25% staining at the top. Sometimes it can be difficult to tell squamous metaplasia. Sometimes we can even spell it right. But a Ki67 can be helpful here, particularly when the P16 is showing block positive staining. This one, what is it? Well, clearly P16 and Ki67 match up and show that this is an H cell. All right, this one here. All right. So is this atrophy? Is this immature squamous metaplasia? Same here. What's going on? We've got a few clues that it might not be normal because the little picket fence down the bottom here has gone. We've got some hyperchromatic cells near the top, but we don't have any mitoses, and if there's no mitoses present, it's very hard to make a diagnosis of H cell. Here we've got preservation of the picket fence almost. We've got some edema, so we've got some inflammation here. How much of this is inflammation and how much of this is CIN? After making a careful observation and looking for atypical mitoses, I pretty rapidly at this point reach for the P16. Okay. So the P16 in both of these is telling me that this is definitely H cell. And if I wanted confirmation, the Ki67 meets the criteria of more than 50% and more than 25% at the top. So sometimes H cell can be deceptively bland. So if it doesn't look like a classic L cell or completely normal, don't feel bad, just reach for your toolkit. Okay, how about this one? So we've got a fairly bland looking epithelium, picket fence, yes, definitely there. We've got some mitoses going up to the middle part, and we've got some coilocytic change at the top. So we're suspecting that this is on the CIN1, CIN2 border. P16 is dense and band-like, so it's not terribly helpful. But if we do the Ki67, we can see that that the strong parabasal staining here, it's increased here more than 50%, but is it increased in the top third? So I think this one is particularly difficult. Probably I would settle on this as CIN2 being influenced by the mitoses that were more than halfway, but noting the data point of the P16 being dense and band-like, and noting the data point of the Ki67 being increased, but not in the top third. Okay, so you've kind of got to put it all together. It's like a bit like building a jigsaw. And sometimes sometimes there are cases that are difficult. Okay, so tips of the CIA and CIM1-2 border. LCIL doesn't usually have a high mitotic rate, loss of cell polarity, or abnormal mitotic figures. And the atypia in LCIL doesn't usually involve the basal or parabasal layers. Okay, let's have a look at this, CIN1 or CIN2. I would say that this is an atypical mitosis, so it was CIN2. Here we go. Similarly, abnormal mitosis, straight to CIN2. So doing a P16 won't be helpful here because it will be positive. And if you're worried about CIN1, it could be positive CIN1. And so we go with the most clinical clue, which is the abnormal mitosis. Okay, so I'm going to show you two now, which is which is HSIL and Y. Okay, so this is immature squamous metaplasia in both of them. One's got HSIL and one has got nothing, just normal. So you can see in the bottom one that the nuclei are quite big, and these ones are much smaller. They are less hyperchromatic and they show a weird kind of streaming, right? And this streaming is very typical of reactive or atypical immature squamous metaplasia. Okay, so here we have the cells are big. Now it's hard to kind of keep the ruler in your mind about how big the cells are. So let's think about a ruler that is going to be around. We've got the lymphocyte ruler. They're 3 times bigger than lymphocytes. Here we've got some stromal cells. These are about the same size as stromal cells, not much bigger. Whereas the stromal cells here, there's at least 2 of them per nucleus. But the most important thing is if you see a picture like this with the mucus cells across the top, is to think, could this be HSIL? So the first thing is to suspect that you're in the differential diagnostic difficulty of immature squamous metaplasia versus HSIL with an immature phenotype. Okay, so going back to them, here we're noticing the cell density is decreasing a bit here, whereas it's about the same here. There's lots and lots of differences between each cell. Anisocytosis, anisonucleosis. Okay, but you must do a P16. This is one situation you have to do a P16, particularly when there aren't many mitoses around. So let's have a think about this thing called atypical immature squamous metaplasia. Okay, so sometimes if there's immature metaplasia, it can start looking a bit weird. You can get more pronounced nuclear atypia. About half of these will in fact be HPV infected. Quite a lot will be low-grade viruses. So atypical immature squamous metaplasia is when the nuclei start looking a bit large, and it's a real trouble spot, particularly when it's inflamed. My registrars know I just go, oh, it's another case of inflamed atypical immature squamous metaplasia, and pretty much straight away, once I've made sure there's no atypical mitoses, I reach into the bag and pull out the P16. This is a very typical case of atypical immature squamous metaplasia. We can see that some of the cells are hyperchromatic, and really the organization isn't that great. But these cells here have quite a lot of cytoplasm. They have very bland looking nuclear chromatin. They have nice round looking cell shapes. They're not craggy at all. They pretty much look the same as each other. And any mitoses are basal and normal. So I'm suspecting that this is just atypical immature squamous metaplasia. And hooray, the P16 was actually informative and just shows a non-block positive pattern. Okay, this one here. So this is showing a very typical feature of immature squamous metaplasia. And this is that streaming look. Okay. The basal cells are intact and not abnormal, and the cells look relatively bland. And if we pull out our helpers here, we can see there's hardly any key 67 staining, and the P16 is definitely not showing any block positive staining. Okay, so what this actually might be is atrophy. Okay, sorry, apologies. I'm just going to go back to this one. I'm not going to re-record this video, so you get all my mistakes in the video. This is actually atrophy. So this would be an appearance in an older lady, and this is why we're getting the streaming as well. And these cells might have the nuclear grooves if we could see them a bit better. Can we? Not really. So this is probably showing some transitional metaplasia. Okay, so atrophy, this is why it's so low, because there's just nothing happening in this epithelium. So atrophy can also sometimes mimic H cell, but the P16 is absolutely negative in atrophy. Okay, on to glandular lesions. Right, here we go. This is SMILE. So SMILE is a variant of adenocarcinoma in situ, in which the cells retain intracytoplasmic mucin. Okay, it's relatively uncommon. It shows other features of HPV-associated adenocarcinoma in situ, in that there's usually numerous mitoses. And the differential diagnosis of SMILE is actually whether it's CIN3, which is just crawling underneath an area of immature mucin-containing epithelium. And the way you tell the difference is you do a PAS, because if it's SMILE, then the PAS will be positive inside the cells. Sorry, the PSD will be positive inside the cells. Whereas in squamous epithelium, the PASD will be negative. It's always P16 positive. Key 67, it's going like crazy. These aren't helpful to tell it between squamous, in situ lesion, and SMILE. Do that PASD. Okay, AIS. So this is a typical morphology of HPV-associated AIS. And what is that typical morphology? So the cells tend to be, a bit elongated. They are pseudostratified or truly stratified. And you get lots of apoptosis, right? So tons of apoptosis. And you also get numerous mitoses towards the epithelial surface. So this is what HPV-associated AIS looks like. If you're lucky, you can find where it cuts off. And these are the normal epithelial cells. Notice how small and innocent these basal cells look. Sometimes they do get reactive change. So like this, what's this? It doesn't have the pseudostratification. It doesn't have the numerous mitoses. There might be a bit of apoptotic rubbish around, but it's going to be mainly from the neutrophils. So this is inflamed, normal glandular epithelium. Okay, P16 will be non-block positive, and it can be useful if you're wondering whether or not it is AIS, but the most useful thing is whether or not there are mitoses there. Okay. So yeah, so the nuclei in reactive change have reactive change in the glandular epithelium means the nuclei can become enlarged with prominent nucleoli, but they lack that true deep purple hyperchromasia, and they have very few mitoses. Yeah. Sometimes you can get degenerative nuclei, and they can be a bit pleomorphic, but the nuclei is often, sorry, the chromatin's often smudged. So this one here shows really nice single layering, but sometimes it can look like this, where you can get 2 or 3 layers of nuclei, and you might think that this is the multi-layering of AIS, but in fact this is reserved cell hyperplasia. So why is this not AIS? How can we tell the difference? Again, the cells lack hyperchromasia. They have got little nucleoli. There's no mitoses at all, and there's no pleomorphism. So remember, reserved cell hyperplasia. Okay, so this was inflamed endocervical epithelium, which means that it showed a bit of reactive atypia with reserved cell hyperplasia. And we don't want to mistake it for AIS. And if we're ever worried, we do want to do a P16. How about this one? Complex glandular pattern, bit of hyperchromasia, but look at that inflammation. So this is inflamed microglandular hyperplasia. Yeah. Usually it's morphologically easy to tell by the surface because it's got quite a lobular configuration. And then we've got lots of mitoses, sorry, lots of neutrophils. Again, the nuclei don't really show pleomorphism, though it's quite a complicated glandular pattern. There's only one cell layer. Okay. So don't be fooled by inflammation. It can cause mild atypia in the cells, but never severe atypia. And where are the mitoses? There are no mitoses here at all. Okay. So even when inflamed, the mitotic figures are uncommon, and there's a lack of pseudostratification, and there's minimal atypia. How about this? Is this AIS? Well, no, because this is what this section's about. This is tuboendometrioid metaplasia. This is showing a very tubal morphology. We can see the intercalated cells and the cilia. Okay. It lacks the small basal nuclei of the endocervical cells, and often it's found in the upper endocervix. So just be aware that this is really, really common, and it's not AIS. No mitoses. So sometimes it can become atypical, particularly if it's inflamed. Yeah. However, no mitoses, no pseudostratification, and our best friend P16 is, of course, non-block positive. Okay, so P16 negative. Right, so there's a little rule with tubal metaplasia and endometriosis. So it can show positive patches, right? It's non-block staining. It's not abnormal, but it's more than people will see in endocervical glandular epithelium. So it's often focal and not that block positive that you see in AIS. Of course, the Ki67 is going to be really low. Okay, so generally in AIS, more than 30% of the cells will stain positive. So here we go. Here's AIS. We can see the block positive P16 staining, no worries. Of course, we do have to do P16 staining under the new classification of squamous intraepithelial lesions if they're invasive as well. Do we have to do it in AIS? I don't do it in all AIS because sometimes they just have the HPV morphology, but it is good practice, so we can say that it is HPV associated. Ki67 going like crazy. All right, how about this one? We do seem to have some pseudostratification here, but not a lot of atypia or mitoses. This is the P16, right? This is the patchy look that you get with tuboendometrioid metaplasia. There's more than 6 cells positive in a row here, but in general, the morphology with the no mitoses and lack of atypia and this patchy nature will tell you that this is tubal metaplasia. Okay, so here in this talk, I've tried to illustrate difficult areas in squamous intraepithelial lesion diagnosis, how P16 and Ki67 can help, some H&E diagnostic clues, and I've run through some difficult decisions with smile and glandular lesions. Thank you for listening.